My topic is to talk on screening for fatty liver. So I'm going to use this new term, metabolic dysfunction associated steatotic liver disease, throughout my talk. So my objectives for this morning to ask you why we should be screening patients with diabetes for MASLD, and what do the guidelines say about the topic, and how to appropriately screen diabetics for MASLD, and talk on common mistakes that we do when taking care of patients with diabetes and MASLD. To start with this patient who unfortunately passed away. So this I've been telling about this patient many a time before, because I am going to tell it again and again because it's a very good example for for us to learn about the risk of diabetes, risk involved in diabetes patients with fatty liver. A 55-year-old man, so age is very important. Long-term treatment for type 2 diabetes, complained to the clinician of loss of weight for 6 months, and the clinician attributed it to metformin. We all know that a lot of diabetic drugs can cause weight loss, like empagliflozin, GLP-1 agonists like liraglutide, even metformin. So the clinician attributed it to metformin. Then the patient had a strong family history of cirrhosis. That again is very important. Then the patient's siblings, which included 2 consultants, wanted a second opinion, and the patient was later diagnosed to have multifocal liver cancer with cirrhosis, and the patient succumbed in 2 months. So could we have prevented this embarrassing, unfortunate scenario by screening? The answer is yes. With proper guidelines in effect from 2019 onwards. So that was when the American Diabetic Association introduced screening diabetes patients for fatty liver. That was 2019. So now this should not happen. So now we could have screened him for MASLD early in the illness. So then we would have detected cirrhosis pretty early. All patients with cirrhosis should undergo surveillance for liver cancer every 6 months. And if the liver cancer was detected early, then it could have been very easily treated. So are diabetics routinely screened for MASLD? Answer is not yet. So things are beginning to change 2019 onwards. But at the same time, I must tell you that diabetics are very well screened for other macro and microvascular complications. My colleagues are going to tell you about those. So is MASLD a neglected complication of diabetes? Answer still is yes. Answer is yes. So in Sri Lanka, who is looking after diabetes patients with fatty liver? So obviously general practitioners, physicians in internal medicine, endocrinologists, and some cardiologists, Ayurveda physicians, quacks, and patients themselves happily look after their diabetes sometimes. They go to the pharmacy, buy some metformin, they themselves check sugar, and come and tell us, doctor, I haven't been to a doctor, but I have been managing my diabetes pretty well. That's how they understand about their disease. How big a problem is this? About more than 10% of the world population has diabetes, And more than that, about 30% of the world population has fatty liver. In Sri Lanka, middle age, more than 50% have fatty liver. And almost all diabetics have fatty liver. But fatty liver patients, all of them won't have diabetes, but they are going to develop diabetes in the future. But the surprising data is not that. About 15% of patients with diabetes and fatty liver, they already have advanced fibrosis, and this figure in Sri Lanka is about 20%. We have just done a study at Ragama, screening 350 odd patients with diabetes and fatty liver with the FIB4 score, then moving into FibroScan. 20% of them have started liver fibrosis needing some hepatology input. So that's not good news. So they are the people facing slow death over next 15-20 years. They are going to develop cirrhosis, decompensation, and liver cancer, maybe. So those are the high-risk patients which should be detected by screening and started on appropriate interventions. So I told you about 2019, 2021. Those are the years where these clinicians, diabetologists started thinking about screening diabetics for fatty liver. So these are the papers from that era talking about this nexus between diabetes and fatty liver. So like in cardiovascular illnesses, if you have the fatty liver patient has diabetes, the risk of moving into cirrhosis is much higher, and the risk of getting liver cancer is also much higher. It's not a good combination to be having. So after going through all these publications in 2019, for the first time, American Diabetic Association recommended screening all diabetics for elevated liver enzymes, and for fatty liver, that's MASLD. And the third part is that the staging of the fatty liver, so whether there is already fibrosis setting in. So that's the important part, not just detecting fatty liver, but if there is fatty liver, at what stage of fibrosis. That's where we are right now. So next step is, how do we screen diabetics for MASLD? Obviously, all diabetics should have ultrasound scan to see whether there is fatty liver. If there is fatty liver, you have to exclude other known causes, especially if there is elevated liver enzymes, like transaminases are high, then you have to routinely exclude other liver diseases like alcohol, maybe hepatitis B, and if they are extremely high, then maybe autoimmune hepatitis in females. Then you diagnose fatty liver, then you move into doing the FIB4 score. So I'll tell you what FIB4 score is and how easy it should be done. Then this is not exactly evidence-based, but justified in diabetics, especially in South Asia. We all know that even with half cardiovascular disease, we do have very bad genes. Same with liver. We all develop cirrhosis at a much earlier stage, and our cancer rates are also very high. And the ideal frequency for doing FIB4 is maybe yearly in diabetics, and if you don't have diabetes, maybe every 2 to 3 years. So this is FIB4 score, very easily done on your smartphone. It's an app. Just you need the age, the AST level, the ALT level, and the platelet count. So all diabetics should be screened with the FIB4 score every year, just like you send them for eye referral, just like you send them for albumin creatinine ratio in renal. Just do the FIB4 score. You just need it won't cost you more than 1,000 rupees. age, even if you are working in the private sector, age, AST, ALT, and the platelet count. And I will give you two examples. 30-year-old with elevated ALT, that's 80, AST 40, and platelet count of 240,000. FIB4 is 0.56. So it's very much lower than 1.3, which is the cutoff. And for this person, FIB4 score in 2 to 3 years is sufficient. But because he has a fatty liver, he should undergo all the screening for metabolic risk factors like diabetes, IGT, hypertension, ideal weight, obesity, right? And you start lifestyle modifications in them. Then he can undergo FIB4 score every 2 to 3 years. But see this patient, seemingly innocuous. No, just when you glance at it, you don't see a major difference, right? ALT is lower than the previous case, AST is slightly higher, platelets have dropped slightly, but see the age. Or at this age, you won't pick this unless you do the FIB4 score. Just do the FIB4 score and see the FIB4 is 2.05, this high risk, right? This person is the one who is going to need a fibroscan. This is the one who is going to face slow death in 15 to 20 years. So then fibroscan, unfortunately, we have, I think, only 2 or 3 fibroscanners for the country, but I'm sure we are going to get few more soon. Fortunately, we have one at Ragama, so we can do research and send patients there. And even for others, gastroenterologists, they are obliged with all the requests for fibroscans. So no major worries there, right? So you should be familiar with this fibroscan report. So this 204 is the CAP4, it's a measure of steatosis, how much of fat is there. Then 3.5 is the liver stiffness. That's the important figure, the number here. If it is more than 8, then there is fibrosis and that patient needs liver specialist referral. So 3.5 is fine and 33 is cirrhosis. So above 8 is fibrosis, above 20 cirrhosis. So second picture on the right side is a report of a patient with cirrhosis where the fibrosis score is 33. So screening patients with diabetes, this is what I'm going to concentrate on now. So do the FIB4 score, and if it is less than 1.3, you see the patients every 1 to 2 years, 1 to 3 years, depending on the risk factors. But for diabetes in Sri Lanka, I recommend doing the FIB4 score every year. Then if it is between 1.3 and 2.67, then fibroscan or any other method, but we don't have any other methods, but we have to go for the fibroscan. That's plan A. Then if it is less than 8, remember the number, if it is less than 8, again lifestyle changes and do the FIB4 scoring after 1 year. Then if the fibrosis score is more than 8, that the liver stiffness is more than 8, that patient needs referral to a liver specialist. But now we have a plan B, but if you don't have a fibroscan, what are we going to do? So these are patients who are, this fibrosis is a very slow process, okay? Sometimes this FIB4 score changes rapidly with interventions. You start something like empagliflozin or GLP-1 agonist or lose 10% weight loss, it reverses rapidly. So if you don't have facilities for a fibroscan, if the patient is perfectly well, you can use this plan B. To initiate lifestyle changes, start the correct medicines, appropriate medicines for diabetes and fatty liver. So there are a group of medicines, right? And then reassess and see whether FIB4 score comes below 1.3, right? And if so, they can be reassessed 1 year. And if the FIB4 score is 2.67, that's more likely cirrhosis, straight away refer to the liver specialist. So interventions include lifestyle changes, treatment of comorbidities with appropriate drugs, right? So drugs, diabetic drugs that are beneficial to the liver, that's pioglitazone, empagliflozin, and GLP-1 agonist, not sulfonylureas, not insulins, okay? Common mistakes that we all do: not screening for diabetes patients for fatty liver and advanced fibrosis. So diabetes patients coming to you, if we haven't done ultrasound scan, and if you diagnose fatty liver, if you are not going to do a FIB4 score, it's a mistake. Being unaware of the fact that about 1 in 5 diabetics with fatty liver already have advanced fibrosis, and they are facing slow death that I mentioned. So they need to be picked up and referred to the liver specialist. Still relying on AST, ALT gross values and ultrasound scan grading 1, 2, 3. People try to make it 2 from 3. No, it won't work, right? Unless you do the ratios, that's FIB4 score and the fibroscan, you are not going to pick up advanced fibrosis with the gross values or ultrasound scan grading of fatty liver. Not knowing diabetes drugs that may benefit fatty liver, right? That's a mistake that we do. Being unaware of the fact that interventions do work in fatty liver with advanced fibrosis. Thinking liver transplantation is the solution for patients with cirrhosis. Absolutely not. Liver transplantation is absolutely difficult. It's not for a third world country. 15 million rupees outside, and that same cost here, even for the government. Okay, so answer is prevention of decompensation. You should not let these people when decompensate and have a liver cancer. No, right? Prevent decompensation and liver cancer, not wait to transplant. To summarize, ladies and gentlemen, cirrhosis due to MASLD is rising alarmingly and difficult to deal with it because mainly due to comorbidities. By the time they develop cirrhosis, they already have blocked coronaries, they already have CKD. These are very poor transplant candidates, right? So you should not allow them to go into that stage. Clear guidelines are in place for past 6 years, and referral guidelines are there. Referral pathways are very clearly mentioned. So there is no excuse for not knowing all these and letting patients come to us with liver cancers inoperable. Physicians should be familiar with latest development of the field of MASLD, like FIB4 scores, fibroscans, surveillance guidelines, interventions, and very recently FDA approved resmetirom, a drug for patients with liver fibrosis due to fatty liver. It's available in Sri Lanka, 1,000 rupees a pill. You have to take 2 to 4 years. And referral pathway, when to refer to the hepatologist, is when the patient has fibrosis. Thank you very much.